Welcome back to Plastic Surgery Untold, greatest podcast in the world. We've got a special guest all the way from the East Coast, Dr. Mark Epstein, who is actually really overall world renowned for his breast augmentations. He's actually designed some very cool breast instruments that many of our plastic surgery colleagues probably use in their practice. But we're going to talk today about rapid recovery breast augmentation. I think it's something that has become more and more popular as we all live busy lifestyles. Most of us are back in the office working, and so let's jump into it. Dr. Epstein, you want to maybe tell people what rapid recovery breast augmentation is? I feel like plastic surgeons use these terms interchangeably, but what does it really mean?
Well, the terms are used a little too interchangeably because all rapid recovery isn't the same thing.
Mm-hmm.
And my mentor in this was John Tebbets. I have to credit him with this. And back in 2001 or two, I went to an ASAPS meeting in San Antonio, and he presented this idea of 24-hour breast augmentation recovery. There had to be 500 surgeons in the audience. Now, this is 20 years later. How many people are talking about doing 24-hour recovery? I can only name maybe a dozen. So I guess people just weren't keyed into what he was talking about, but I was fascinated. So I said, John, I got to come visit you. And in 2004, I went there, and my practice has never been the same since. And what it is it's really not a procedure, it's a process. And it begins with education of the patient, understanding what implant sizes are ideal, what aren't. The surgical procedure itself is very atraumatic. It's a nearly bloodless procedure. Sometimes we barely lose a few drops of blood. It's crazy. But the atraumatic dissection, you're going through natural tissue planes. There's no ripping, no tearing, no blunt pulling. Postoperatively, it's a certain set of instructions. And the whole process gives a recovery, which we use the term, he used 24-hour recovery, I use one-day recovery. Ash Ghavami does it. In California, he calls it flash recovery. It's all the same exact procedure. There are people who talk about rapid recovery, and this is where it gets a little vague and nebulous. You know, what's rapid? Is it a day? Is it a week? Is it a few years? I was doing the procedure, as I said, since 2004, and in 2013, an article came out in our White Plastic Surgery Journal where Eric Swanson talked about 225 consecutive recoveries from breast augmentation, and he found that they needed 5 to 6 days of narcotics and a month to feel good. And my patients, I've been written more than I've been written a narcotic prescription for breast aug in probably 8 years, and I think overall maybe 1% or less. So another surgeon had reviewed the article and said, the discussion followed in the journal right after it. It said, thank you for such an honest discussion about breast augmentation recovery, not the dubious distinction that recovery could really occur in 24 hours. Well, John and I wrote letters to the journal. The journal ended up printing a retraction. The fact is that patients do recover in 24 hours. I have videos of patients immediately after surgery in my recovery room putting their arms up like this with no pain. And they go out to dinner the same day. They go shopping the same day. Some have sex the same day. I called one patient after surgery, as I always call them, and I said, how are things going? She said, got home from the gym. I do let them go on a treadmill and do fast walking, but not running. So supposedly that's what she was doing. But this is
And Mark, I think you hit on some points that are just so important that have changed. The old days of breast dogs, and I remember training when people would do these blunt dissectors, and as we splash some cold water in there, and one, I think it's the rapid recovery is obviously a huge part of this, but the precision, the shape, the reproducibility, the capture contracture rates, all of these things, because I truly think blood in the pocket, I think being super precise for the size of the pocket, not only is rapid recovery, but where does that implant sit, not just 2 weeks from now or 3 months from now, but 3 years, 30 years from now. And so all of those things to me are priceless in terms of our technique and long-term outcomes. It's been a big push by us, and because we want our patients to be happy, not just for the 3-6 months that we're going to follow them, but for, the hopefully years and years to come. But, how do you decrease reoperation rates? And some of it starts from day one of being so meticulous in terms of your procedure and technique.
Yeah.
well, you just hit upon the key point about reducing reoperation rate. John Tebbets published in the journal 50 consecutive procedures with a reoperation rate of 0 at 3 years. That's unusual, but for people like myself who do the procedure that I mentioned, we all get about 2% reoperation rate. And if you look at the data submitted to the FDA when implants were, silicone gel implants were put back on the market in '06, Mentor and Allergan submitted 15 and 40% reoperation rates at 3 years. That's crazy. Who would do that? Would you open a business that had a 40% chance of failure in 3 years? My patients, it's about 2%, and that includes reoperation for every reason under the sun. That's the real benefit of the procedure. It's not so much the fast recovery. The fast recovery is a nice benefit, but the real benefit is that the revisions I'm doing are generally on other patients, other people's patients. Very few are on my own.
Yeah. I got a quick technical question that hopefully we can keep simple. You had mentioned one of the key ingredients for rapid recovery in your practice was operating in natural tissue planes. And there are many breast augmentation techniques that are partially submuscular and require cutting into the muscle, which I never have liked doing. And for that reason, or at least I have, and I think many of us, or all three of us, have migrated in some patients at least to a subfascial prepectoral technique. What are you doing so that you are kind of living up to what you just said, where you are really just in tissue planes?
Okay. You do have to transect the muscle, and I use the cautery. But when I do it, I'm very careful that I'm only pulling up, and I use, to get technical, John Tebbets has a double-ended breast retractor, and the narrow end of it is very good at holding the incision up and putting very gentle tension on the pec muscle, so you can see the pec muscle on minimal stretch, but no real tension, just enough to transect it easily with the cautery. And it does not result in a lot of post-op pain. I do subfascial augmentations, but I would say that 99+% of my procedures are dual plane 1, 2, and 3 procedures where I transect the lower edge of the pec and I get these recoveries. And no magic to it because people that I have taught the procedure to get the same recovery too.
Are you injecting
the pec.
Are you injecting any local into the muscle in that region?
That's a great question. I found that patients post-op have a little bit of stinging in the incision, so I put 4 cc's of more into the subcutaneous tissue on the lower edge of the incision only. I don't even inject the upper edge, and because that tends to get denervated by the incision anyway. And so I'm putting nothing in the muscle. There was a recent article that I was asked to review for PRS on, they were doing a study where they were doing either intercostal nerve blocks or putting tumescent local, like a couple hundred cc's into the muscle. And it was crazy because not only is there risk of pneumothorax, but I don't know how you assess the contours of a breast with 200 cc's of fluid in it. But it was ludicrous. The operative times were an hour and a half to 2.5 hours, where my operative times are typically 45 minutes. There's just no reason. I mean, I've got thousands of surgeries I've been doing for 19 years that I can prove you do not need to inject anything into the breast other than the few cc's of Marcaine if you want. You can transect the pec, and dual plane, you're then doing a subfascial elevation of the gland and the fascia off the muscle up to either the level of the nipple or the top of the areola. And the post-op recovery is very consistent.
The part that you brought up that we've adopted not only in our breast dogs, but our tummy tucks and almost every aspect, and it's been a huge change for us, is the early mobilization. I think the old days of being in bed leads to stiffness, to chronic pain, to risk of DVT, blood clots, those type of things. And your point of getting people up and moving the day of surgery, I think is critical. Breast dog obviously is a good one, but I think really in every procedure that we do, Dr. Arredondo.
Yeah, there's a point in there that I also want to touch on, but it's not just the technique of the procedure. Like we talk about, oh, you're making an incision this long, this position, you're dissecting this plane. It's also how we do the procedure. It's how we retract. That minimal tension on the tissue to let that minimize the damage to those wound edges. The way we hold the tissue, the way we dissect it, we're so precise. I mean, I love being a general surgeon, but I was definitely nowhere as good a surgeon as I am now as a plastic surgeon after going through that additional training, because my mentors just hounded into me that careful technique, careful tissue handling. And it affects everything we do. And that's where a breast augmentation, where second most common procedure done, aesthetic procedure done in America, becomes so nuanced and so detailed, and why it's so important to go to somebody with the right training.
And your tension thing is so interesting because I've
Hmm.
changed that even with my
Hmm.
mastopexy Augs, with, tummy tucks, because I do think that if you just, the old days of the, not to bash on my orthopedic colleagues, who, want to be as strong as possible, but I think sometimes well-intentioned assistance trying to help you can be very damaging to the tissues, to blood vessels. The old days of just putting these big hooks on mastopexies to lift those skin flaps, I feel like you shear those blood vessels. Same thing with breast aug tummy tucks. Somebody just trying to be as strong as possible can be a little counterproductive.
Yeah.
Well, that's a great point. I remember in general surgery, if I tried to hold my own retractor, I get reprimanded for it. But the reality is, when I'm doing a breast surgery, when I'm doing a tummy tuck, I use the retractors. I hold them myself because I want to control the tension, and I'm not working hard. I'm barely expending any effort. When I designed those retractors, I actually wasn't thinking of designing retractors for everyone else. I was having terrible shoulder pain from the ergonomics of trying to not pull hard on the tissues, but be able to, at the same time, to still see everything deep in the pocket. I just couldn't see far without pulling hard, and my shoulders were killing me. My orthopedic friend was injecting me with steroids, and I said, "There's got to be a better way." So I put on my engineering cap, which is what I studied in college, and I designed these retractors. And I just wanted them for me. I wasn't thinking of anything commercial. It turned out for the breast, it biomechanically made sense. It unloaded my shoulder. I didn't have any more pain. Surgeries were easier, quicker. And the interesting thing is, my 1-day recovery went from 80 to 99% just when I switched to those retractors. Now, that's me. I'm not saying if you buy the retractors, your recovery will improve, but that's what I had observed. And then for tummy tucks, I was just struggling terribly, as you all do. When you're trying to lift in the upper abdomen, that big flap of tissue, and all the conventional retractors just slip. These retractors, with a little modification in the design, worked great. Disclosure, I do get a small royalty on the retractors, but they've helped my practice, and I always hold my own retractor.
Can you?
That's so
you
funny. I piss off. I make a lot of our techs a little bit, I think, frustrated because you don't ever let us help you. And I always say, no, I'm just helping you. And I lift the retractor myself, and they're like, we want to help you too. It's like, I got it. I'm good. Just I'm going to help you. I'm going to position it here, because they can't see where you're trying to look. And so they're going to crank on it, and they pull so hard, those blood vessels disappear, and you want to see every little thing so you have 0 drops of blood while you're in the pocket.
Yeah.
You spoke of a process, and I think we have talked about many aspects of it, but would you be able to go over for our audience, kind of from beginning to end, maybe with very brief bullet points, like what is that process? What are the components of a successful rapid recovery?
Okay. Well, the patient has to understand and be on board with the whole process. And I show them videos of people recovering as early as in the recovery room. So they see that it is possible. And when they come because they know people I operated on, they believe it. But I'll be honest with you, the ones who haven't seen it, they still don't believe it even when I show it to them. I take detailed measurements of the breast, not just the base width, but I'm examining the tissue, looking at the dynamics of the upper and lower breast, how stretchy it is, to get a better idea, because the base width sets your basic measurement of the volume, but then you adjust it according to tissue tightness. So I'll show them on a chart how I'll go up or down a little bit. Then I use the 3D imaging, and I explain to them, this is not how we select an implant, but I have an idea based on your measurements and your tissues, what I think would look good. I just want to show you what I'm thinking to make sure we're on the same page. This is important, because if we're not on the same page and they want something bigger, we have to have a discussion, and they have to understand that while I'm willing to do it, it may impact their recovery. Most of the time it doesn't, but it can. So they have to be on board with the process. And then we also talk about 1 day versus rapid recovery. And I have a chart on the website that actually details the difference in the processes. A lot of the people in my area who talk about rapid recovery, and I don't know of anyone in the New York area who uses the term 24-hour, 1 day, or flash augmentation. What they'll do is they'll tell the patient, oh, you won't have any pain, but we'll give you a prescription in case you need it. I tell my patients, you're not going to have pain and you're not going to need a prescription, and I'm not going to give you one. Now, if they say, well, what if I need one? Yeah, if they call and they're really in agony, we'll give one. But like I said, I haven't had to give one in probably 8 years. So, that says a lot. After the surgery, there's a detailed set of instructions they need to follow. And these instructions are designed to reduce spasm in the pec muscle so that they don't need muscle relaxants, and it keeps their pain level low. We do preload them with Tylenol the day before surgery, which we found very helpful. When we started doing that, the need for giving IV Tylenol as a rescue in the recovery room has diminished to almost nothing. We use gabapentin. There's a lot of little tricks in there, but the most important thing is the surgical handling of the tissues.
I love it. We pre-treat people the day before, the morning of. I think for all of our procedures, it's been something that's been super helpful. Maybe I can go, because we're running a little short on time here, but run around the room in terms of what do you typically, Dr. Giordano, we tell people in terms of able to return to work, normal desk job after a breast aug?
I say take a few days off, maybe a week at the most, usually for an uncomplicated breast aug. I've had people who come in on Thursday and they're back at work on Monday.
Dr. Weinfeld?
Yeah, so many people work at home nowadays. I tell them that they likely are going to be able to do a lot of that work, if not all of that work, the next day. If they have to go back to a job, let's say they're a nurse and they're having to move patients around, that they should give themselves kind of the time frame that Dr. Arredondo said. I'm very eager to learn a little bit more about how you approach things. And yeah, public service announcement, Tylenol, acetaminophen, it costs pennies, but it's far more effective than narcotics in terms of its pain relief.
Dr. Epstein, what do you tell people back to work, desk job?
I tell them they go back the next day if they want to. I had a patient where I did her surgery. She was last of the day. About 5 o'clock, we did her surgery. She was a receptionist in a doctor's office. She was back at 8 a.m. I had a woman who is a CrossFit trainer and a restaurant server. She told me her downtime was 6 hours. So I tell patients, if you're comfortable, go back the next morning. You certainly can. Many do. Some people take a day off. I do have a lot of ICU nurses and other nurses. I tell them just get someone else to do the heavy lifting. I let them lift up to about 30 pounds or so after surgery. No worries. But patient nurses taking care of patients, obviously it's dead weight. So just get someone to help you, and that always seems to work. They typically take a couple days off. Hair cutters, a lot of hairdressers that I've done, I let them go back the next day. Some take a day off, but typically 1 or 2 days is all they take off.
And what about over 30 pounds? I usually after 2 weeks, just some of it is still kind of just the fear of a post-op hematoma, bleed from over strenuous, But like you said, if you see everything and you can be super proactive about it, I think that risk is dramatically decreased, and some of that's probably just my own worry work. But Dr. Arredondo, how long?
Probably about 2 weeks, and that's why a lot of the people I see, Austin's got a full. Big group of fit people, CrossFitters and whatnot. And so I tend to be a little bit more on the conservative side, but 2 weeks is plenty of time.
Because I feel like sometimes when you're like, you can do a little more, that little more goes a long way sometimes, unfortunately.
Right.
Dr. Whitefield?
Yeah, I mean, similar, but I love conversations like this because, so much of what we do as plastic surgeons are, they're sort of thoughts and feelings about what's right that were passed on to us without a lot of science. And often when we have a conversation like this with someone who's not even really pushing the limits, but just had the courage to question what we all thought to be true, it pushes me to help out my patients by doing something that is very well established by people that I trust, and to kind of scale back some of the things that may just not make sense. So I'm really going to try to move towards what you've been suggesting, learn a little bit more about it, maybe give you a phone call to find out some of those key secrets that we didn't have enough time to discuss. And I'm going to push myself to do something that's better for the patients.
And little secret, and I'm still pushing him, and hopefully he can work it into his busy schedule. But we're actually trying to get him to maybe come a day early and spend a day with us in the office for when he comes down for ASPS. So I know he's a national speaker and for a few companies. So if we can squeeze a little bit of his time when he comes down to Austin, we would greatly appreciate it.
It would be an honor and a
Awesome, Dr. Epstein. I appreciate you taking the time, and we'll let people know when we're coming because we got a few things that you and I want to talk about, and hopefully still Dr. Weinfeld and Dr. Arredondo, and maybe talk about some breast dogs, maybe some skin tightening stuff that you and I had talked about sharing with people as well when you come down. So thank you again for your Sunday. Thank you, everyone who listens. Plastic Surgery Untold, Rapid Recovery Breast Dog, or one-day breast dog recovery from Dr. Epstein. Appreciate you. You can find him at EpsteinPlasticSurgery.com. He has a lot of stuff on his site. He also has a fabulous Instagram, and so we'll be tagging that and sharing it with all of you guys. So everyone have a great day. Plastic Surgery Untold, greatest podcast in the world. Thanks.
Such a pleasure. Thank you.
Thank you.